Thank you for inviting me, and thank you to everyone who's joining us today. Like Christina said, my name is Catherine, and I'm very excited to be speaking to you today about trauma-informed care and its role, its potential relevance in the domain of chronic pain. I want to take a moment of our time first to acknowledge that McGill and the Montreal General Hospital are in the traditional and unceded territory of Indigenous people, specifically the Haudenosaunee and the Anishinaabe nations. I acknowledge my cultural heritage as a white colonizer and would like to take a moment of silence here to show acknowledgement and respect for the Indigenous people who still call this land home, as well as the Indigenous people who were forcefully removed from their land. As the title of my presentation suggests, we will be touching on and around trauma today. I just want to let everyone know, in case there are some people who might be more sensitive to or triggered by these topics, just to be forewarned of the content of this presentation. I also, before starting, want to let everyone know that there's a little participation section in the middle of this presentation. So I look forward to hearing your thoughts as I kind of prompt this discussion a little bit later. So pain, and especially chronic pain, is hard enough to live with. And now imagine all the daily things that make pain harder to live with: cooking, childcare, stairs, stress, anxiety, living or working in an unsafe environment, microaggressions regarding your race, gender identity, or religion, having a history of trauma. All these factors add up and can create the perfect recipe for a disaster when it comes to chronic pain management and care. Traditional healthcare, our healthcare system as it stands today, struggles to address all of these straws, if you will, that strain on pain patients. So, what if there was a way to reduce the burden of all these factors in a way that could potentially improve care for pain patients? Trauma-informed care is a set of guiding principles for treating our patients in a respectful, collaborative, and empathic, empowering manner, which avoids re-traumatization within the healthcare system. Today, I'll speak to you about what trauma-informed care is, what it looks like, and what research is showing might be the benefits of applying this to our interactions with pain patients. In the rest of this presentation, I'll first introduce research on trauma-informed care and its relevance to pain research and management. Then I'll expand on the definition of trauma-informed care and, like I mentioned, guide a discussion on what this might look like in a clinical setting. And finally, I'll share some research on the potential impact of implementing trauma-informed care in a pain context. But before I get started, maybe just look like a show of real hands or virtual hands. Has anyone ever heard of trauma-informed care? Okay, we have some. I see some thumbs up, some hands raised. Okay, so it's a known topic to some people, but for others, it seems like this is kind of a new thing, so that's good. For those of you who maybe you didn't raise your hand, maybe it did sound familiar, but you weren't too sure from where, it's possible that you might have heard of trauma-informed care through one of the 3 reports that was released by the Canadian Pain Task Force between 2019 and 2021. Actually, all 3 of these reports explicitly mention trauma-informed care, but maybe most importantly, in the context of this study or of this presentation, Their third report, released almost exactly a year ago now, actually mentioned the importance of trauma-informed care in 3 of their 6 main goals, for improving overall access to care, improving the care that's provided through pre and post licensure training, but also for improving access to care for those who are disproportionately affected by pain. And I think as this presentation goes on, we'll get a better sense of why exactly it is that the Canadian Pain Task Force is making these suggestions. Because right now I'm just kind of throwing it out there that the Canadian Pain Task Force endorses trauma-informed care, but maybe a lot of you are wondering what exactly is the link between trauma and pain. So I thought I would start by giving a bit of a history lesson. So in the mid-late 1990s, a research team out of New York partnered with the CDC to conduct what now today is considered a landmark study in health research. Unfortunately, not many people know about it. So Folletti and colleagues assessed nearly 10,000 adults just doing a standardized medical intervention or a standardized medical evaluation, sorry, and then asking these adults to complete a self-report questionnaire. And the self-report questionnaire focused on the adverse childhood experiences, or ACEs, that these adults had experienced. And ACEs subsume many different kinds of difficult experiences one can have in childhood. This can range from abuse or neglect to having someone in the household experiencing substance use difficulties or mental health difficulties, to parental separation through or parental loss through separation or divorce, illness, or even death. And what was so landmark about this study is that they found that, first of all, ACEs are incredibly common, much more common than had been expected. More than half of participants had experienced at least one ACE. But they also found a dose response association between the number of ACEs someone had experienced and their health risk behaviors. So that could be smoking or physical inactivity, as well as diseases or conditions, health conditions in adulthood, such as cancer, skeletal fractures, etc. And just to kind of drive this home, they found that adults with who had experienced ACEs were 2.5 times more likely to develop hepatitis, 4 times more likely to become depressed, and 12 times more likely to commit suicide. So what this study shows us is that the experience of adverse events in childhood not only impacted what health behaviors you engaged in as an adult, but that there was also an association between health outcomes, and they posited even an association between early death. However, the original ACEs study did not assess chronic pain in their adult sample. So do these findings replicate in pain populations? And the long and short answer is yes, but I'll give a little bit more nuance here. We see that there's a relationship between ACEs reported in childhood and the development of pain in adulthood. For example, a longitudinal study from the 60s found that children whose parents reported that the children had experienced ACEs were 1.6 to 2 times more likely to themselves as adults report experiencing widespread pain at 45 years old. But also we see that adults living with chronic pain retrospectively report having experienced ACEs. In a recent 2019 study of adults in a multidisciplinary pain clinic nearly half, nearly half of adults had experienced 3 or more ACEs, and 3/4 of the adults in this clinic had experienced at least one. And you'll forgive my emphasis, but I continue to find this astounding. In that same study, we also see, kind of bringing in a biopsychosocial perspective, that these participants who had experienced more ACEs were also experiencing significantly more mental health difficulties, excuse me, than participants with fewer ACEs. But obviously, I'm presenting certain research results. There is some inconsistency in the findings in the literature, though I'm not an expert, that I could find. For example, a 2011 study found that the relationship between ACEs and pain in adulthood was dependent on the kind of adverse experiences that children had undergone. For example, in this study, they found that only childhood hospitalization was linked to pain in adulthood. And again, another study in 2018 by Ottenhoff and colleagues found that there was actually no relationship at all between ACEs and musculoskeletal pain, though it is to be noted that this was a study conducted not in a chronic pain sample, but in an acute musculoskeletal pain sample. Though this is just my interpretation from what I understand of the findings. So don't take this slide as a full summary of the literature. Actually, we're lucky enough that there is an upcoming systematic review and meta-analysis by Bussière and colleagues that I'm expecting to see out soon, that should help clarify the relationship between ACEs and pain much more thoroughly than my description here. So be on the lookout for that. Now, ACEs might not be experienced by everyone as traumatic. For some people, they might be what we call sometimes little t traumas, as opposed to big T traumas, which is where someone might develop post-traumatic stress disorder or PTSD. So does the relationship still stand when someone's ACE is a big T trauma, is considered or experienced as a big T trauma? Copious amounts, decades of research on the comorbidity between pain and PTSD suggest that there is a similar relationship as between ACEs and pain. So first of all, we do again see a higher prevalence, not only of chronic pain in people with PTSD, but also of PTSD in people who are living with chronic pain. The prevalence varies significantly from study to study, depending on the population. A recent 2019 study found that the prevalence was around 28%, and I apologize for this very binary representation of gender. The idea being that over one in 4 people with chronic pain have PTSD. But also we see that people with PTSD also tend to rate their pain experience as more severe. They tend to rate their pain intensity as higher in comparison to people without PTSD, as seen by the different proportions on this graph. And again, this is coming from the same 2019 study. So although the mechanisms for the comorbidity between pain and trauma are way beyond the scope of this presentation, though I'm happy to talk about it more in the discussion portion of this presentation, I would be remiss not to mention that there are many theories, there are many ways of explaining how these might actually interact or maintain each other. as opposed to kind of just being two separate but comorbid conditions. There are a number of cognitive models, for example, to help explain this interaction and this maintenance, such as the mutual maintenance model, the shared vulnerability model. But we also know that there are a lot of common neuropsychological and physiological processes between pain and trauma. And of course, we also know that both impact on the endocrine and immune systems, just to get a sense of what the interactions might be between these two. So now that we have hopefully a better sense of the potential relevance of trauma-informed care in the context of pain, we've contextualized trauma a little bit in the context of pain. I'd like to help you all understand in a little bit more detail than what I presented at the beginning of this presentation, what exactly trauma-informed care is. I'm just going to mute myself for a second to cough whatever this is out. It's a little bit of COVID still. I do apologize. You might all have to just tolerate my scratchy voice. So this definition that I have on the screen here is provided by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. They're an organization based out of the US, and they've come to be somewhat of an authority on trauma-informed care. And as I go through this definition, I'd like to draw your attention to the 4 R's that are in here. So a program, organization, or system that's trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So the 4 R's give a sense of what being trauma-informed necessitates. And the 6 pillars of trauma-informed care that I have listed here help translate what is the definition of being trauma-informed into trauma-informed care. And rather than kind of go through these and explain each one, what I would actually like to do is switch to the participation portion of this presentation, because I think that maybe going through a clinical example will help us clarify kind of this very abstract concept, I think, into something that's much more concrete. So before we, oh, sorry, Rebecca, to go through the, yeah, I'll go through the rest of these a bit more quickly, so that everyone can have a sense of what some different examples might be of applying trauma-informed care at a clinical level, and in an effort to finish this presentation on time. Peer support is another pillar of trauma-informed care. And I think that in the context of chronic pain, we tend to do this well. There are many, many resources for chronic pain, especially in Quebec. But doing things like specifically telling patients about chronic pain groups in the community, posting ads for community support. I know this was something I thought was really great about the pain clinic when I was there last year, is having kind of these boards where you have ads posting Ami Québec, the AQDC, different resources that are available for people in the community is part of trauma-informed care. But we also have, like I was just mentioning with what Tali had suggested, collaboration and mutuality is a very important part of trauma-informed care, working, I think, Alan, you had mentioned something along these lines as well, working with the patient to come up with a treatment plan, providing a rationale for asking certain things, even in psychology, where some people might think that all questions are fair game, explaining to someone why am I asking about your background, why am I asking about your childhood when you're coming to see me when for chronic pain. These can help create a sense that there's not so much of a hierarchy, one person knows what's best for the other person, but that you're a team working together to help a patient. We have empowerment, voice, and choice as the fifth pillar of trauma-informed care. And again, we're seeing a lot of overlap with other pillars of trauma-informed care, but giving the patient options so that they can choose, creating an environment where the patient feels that they can voice their opinions. I think, Christina, you were saying something about creating an environment where the patient feels that they can share and say what they think. Another really important thing to consider in a chronic pain context might be inquiring about, rather than assuming, reasons for non-adherence. If a patient didn't take the medication that you prescribed them, maybe there was a reason for it, or highlighting strengths and skills that a patient is demonstrating, rather than uniquely focusing on their difficulties. And I think the final pillar of trauma-informed care might be the most complicated or least intuitive: cultural, historical, and gender issues. And this is something that needs to be done outside of patient interactions. This is something, clinicians can do to apply trauma-informed care, but that we can all reflect on as human beings, trying to get a sense of what our own biases are, what our perspectives are, and what other people's perspectives are, and seeing how that might color and infiltrate into our clinical interactions or our research interactions with pain patients. This is, like I said, very important, but not as intuitive, because this is something that requires self-educating, self-exploration. Now, trauma-informed care can be applied at the individual clinician level, but it can also be applied at the organizational level. This can be as simple or straightforward as offering a patient different means of having their appointments, or it can be more complicated and focus on educating staff on the population you're working with. In our case, in the chronic pain population, the biopsychosocial model, and educating kind of all staff beyond just the clinical staff on what trauma-informed care looks like. But ultimately, at the organizational level, what we really need here is an organization to kind of make a statement, adopt a policy or a mandate that centers around trauma-informed care and a commitment to bringing trauma-informed care throughout an organization. I want to make one last note here about trauma and trauma-informed care before I go back into the research for a short while. I don't think it's necessarily been made explicit up until now in my presentation that engaging in trauma-informed care is different from engaging in trauma-focused care, which is care that focuses on treating trauma. Trauma-informed care doesn't necessarily seek to treat trauma, but works within a framework that acknowledges the presence of trauma in many people. And actually, some people even go one step farther, like in this 2020 article in JAMA Pediatrics, by suggesting that you don't actually even need to assess trauma, and that you can simply use trauma-informed care for everyone, that you can simply apply trauma-informed care as a universal precaution, that maybe it's just good clinical practice to work within a trauma-informed care framework. So I hope that now you all have a better sense of what exactly trauma-informed care looks like in practice. And now in this last part of the presentation, I want to shift to sharing some emerging research on the impact of implementing trauma-informed care on patients. So here we have a study that was conducted. I actually think, Ken, maybe you were implicated in this study. This was a study conducted by a team out in BC, implementing equity-oriented healthcare, which includes being trauma-informed in the healthcare that you're providing. And what they did for this study is they implemented this form of care in 4 primary healthcare clinics, and they followed patients for 2 years. And what they saw was that how patients had experienced equity-oriented healthcare, and by proxy trauma-informed care, was not only significantly associated with how confident and comfortable they felt about the care that they've received, but that it had downstream effects on patient-reported outcomes, the things that we would normally be looking for improvements in a chronic pain population, like quality of life, disability, PTSD symptoms, depressive symptoms. There was a quantitative, tangible outcome of applying equity-oriented healthcare, and as a consequence, trauma-informed healthcare. But there's another way that trauma-informed care impacts patients. And I'd like to take a moment here to let everyone read the account of this person living with pain. I think it's clear from reading this account that this is not someone who felt humanized in their care. This isn't someone who felt valued or seen. And one of the things that I want to drive home about trauma-informed care is that maybe in starting to research and clinically apply trauma-informed care, we also need to think beyond these easily measured outcomes like pain severity and pain disability, and think about how the people coming through our systems, our healthcare systems, might be impacted by the system, and how trauma-informed care might positively impact them. Do they feel more recognized? Do they trust their healthcare professionals more? How are they internalizing their interactions within the healthcare system? But also, and this is a point that comes straight from Sandra Woods, how are the healthcare professionals experiencing their interactions with patients? How are the healthcare professionals internalizing their interactions? I think that there's multiple sides to this that need to be considered, not only the patient perspective, but also the healthcare professional perspective, and of course, the healthcare system as a whole. So needless to say, I think from what I've just described, so there's a lot of research left to be done to even get a good sense of the impacts of trauma-informed care. We still don't have a good sense of what pain populations might respond to this best. We don't have a good sense of how we might implement trauma-informed care in a pain context, what that would look like, what patients want, what healthcare professionals want and feel competent in doing. and what's possible within the confines of our healthcare system. But also, we don't have a good sense yet of what the mechanisms of action might be for trauma informed care if it positively impacts these kind of patient reported outcomes, and beyond, how it's doing that. And I'm proud to say that I have started delving into the world of research on trauma informed care with my friend and colleague Arthur, who I think is joining us today. And so be on the lookout for something, hopefully, in the coming months on that. And I also wanted to kind of throw it out there that I've actually just finished a course on non-pharmacological clinical trials, and I've developed a whole trial around the implementation of trauma-informed care. So if anyone has research funds and wants a study that's already kind of ready to go, I'm happy to speak more about that. If you're still interested in knowing more about trauma-informed care, there are lots of ways of educating yourself. There are lots of good professional trainings, but there's also lots of ways to do your own learning. I'm happy, if anyone is particularly interested, I'm happy to send out these resources as well as any other ones I can think of. And I think I want to leave you all on this note. And again, this is inspired from my friend and colleague, Arthur. Chronic pain is kind of like living in a village that has a contaminated well. The water is contaminated. People might get stomach aches, might have some indigestion issues. Some people might die. But if we continue to focus all of our energy on treating the stomach aches and the digestion problems, we're never going to address the water that's getting all these people sick. I'd like to thank lots of people. Some of them are on this slide, and also disclose my financial support for my PhD. And I'd like to thank you all for joining me today. My contact information is here for anyone who's interested. Thank you.